I want to thank the organizers for the privilege and hope I didn't run a couple minutes off while I wound up here, because we now know they will cut the slides off. These are my disclosures, and I don't know that I'm going to argue that you should. I'm going to try to examine when should you. And here's what I'm going to try to cover. Some of this very quickly because I only have 8 minutes, but I'll be speaking in Toronto about this in a little more depth. 3 methods of stroke prevention and make the case for left atrial appendage elimination. So the keyboard works a little better than the mouse, I see. What methods of surgical closure work and which don't, and when should the left atrial appendage be closed? And we'll try to break it down into these 3 different categories of patients. Now, this is my last slide. This is the take-home message, just in case I get cut off. Surgical closure methods, suture closure methods don't work. And we can't seem to get this through our heads. As surgeons, we want to believe if we sew it closed, it's going to stay, and it doesn't. In trial after trial after trial, it reopens. In general, surgical exclusion methods recanalize. Surgical excision is effective. If you leave a scar, it's going to heal and stay that way. The clip, which appears to be an occlusion method, however, does work, and I think the reason it does work is it leaves a line of necrosis. There is adequate data to support left atrial appendage closure in the presence of pre-existent atrial fibrillation. There's no data to support routine closure of the left atrial appendage in the absence of pre-existent atrial fibrillation. And it may lead to higher rates of postoperative atrial fibrillation. More data is coming for the populations at high risk. Now, let me try to make the case for these points that I've gotten here. 3 approaches: ablation of atrial fibrillation, oral anticoagulation. Both have some limitations, so let's focus on, I'm sorry, I went the wrong direction here. So let's focus on elimination of left atrial appendage. Methods of doing that, there's been a lot of data about this, and I don't have time to present it all today, but as I said just a second ago, exclusion recanalizes, excision works, the clip works because it leaves a line of necrosis that then heals. It effectively acts as an amputation. So when we're reading the literature, we can't just say, well, that closure of the appendage was ineffective. You have to make sure the method used in that paper was an effective measure of closing it. So who then should have that done? Well, let's start at patients with a history of atrial fibrillation. There's this paper from 2018, interesting paper, 10,000 patients, mean age of 76. Third of them had closure, and after adjustment, there was lower thromboembolism, lower all-cause mortality, but not hemorrhagic stroke. And in subgroup analysis, this protective effect was seen in patients discharged off on oral anticoagulation, but not those who were taking oral anticoagulation. Here's a good paper from 2015, surgical appendage occlusion in patients with atrial fibrillation. Here, looking at stroke, we see that at 30 days, in this meta-analysis, it is indeed protective against stroke, and that persists at latest follow-up. And indeed, in this meta-analysis, it was also protective of mortality at 30-day mortality. Didn't have a longer term to that. In fact, this was the paper that was referenced to lead to this Class 2A recommendation in the Society of Thoracic Surgeons Guidelines and Treatment. What about patients without a history of atrial fibrillation? It's an interesting paper. This was 9,000 patients, but only resulted in 461 propensity-matched pairs. 54% had no history of previous atrial fibrillation. Unfortunately, they didn't do subgroup analysis of those that had pre-existent and those who did not. And here's what they found. They had analyzed to look for postoperative early postoperative AFib, stroke, and mortality. What they found was left atrial appendage closure was independently associated with an increased risk of early postoperative atrial fibrillation. Kind of counterintuitive, not sure I understand that. Left atrial appendage closure did not significantly reduce the, influence the risk of stroke. And closure did not significantly influence mortality. Like I say, they don't make intuitive sense, but this is a large study done by very senior authors from excellent institutions. A little difficult to interpret because they mix together patients with and without preoperative atrial fibrillation. Now here's the paper that we were waiting for and is going to help guide us a little bit. This is the paper of 75,000 patients who had, a third of them had pre-existing atrial fibrillation. Out of this, we got over 4,000 propensity-matched pairs of atrial appendage closure versus no closure. Overall, left atrial appendage closure was associated with reduced stroke, reduced mortality, a higher number of outpatient visits, a higher rate of rehospitalization, which I'm not sure I understand, but you know, when you're dealing with numbers these big, little things can become significant. An increased risk of postoperative atrial fibrillation. We're seeing that prop up again. Now, the important thing in this paper, as I said, was they did a subgroup analysis. And for stroke, if you looked at patients with pre-existing atrial fibrillation, there was definitely a difference. There was stroke reduction when you ligated left or amputated left atrial appendage. If you did not have pre-existing atrial fibrillation, there was no difference. Mortality, we see the same thing again. If you had pre-existing atrial fibrillation, there was a mortality benefit. Look at how far this study went out. The mean follow-up was over 2 years, and we got follow-up up to 4 years here. Without postoperative afibrillation, no difference. So in summary, patients with pre-existing atrial fibrillation, left atrial appendage occlusion resulted in decreased mortality, decreased stroke, but not if you were discharged on oral anticoagulation. Increased readmissions and outpatient visits. Patients without pre-existent atrial fibrillation had no reduced mortality, no reduced stroke, increased post-op AFib, which I still don't quite understand, no increased rate of hospitalization. So the question then is going to become, can we identify groups at high risk? Well, I'm going to burn through these last couple slides very quickly. And we're going to have to wait a little bit because there's 2 studies currently in enrollment complete. LAOS 3 looked at patients with pre-existent AFib. Enrollment is completed and they're in follow-up. And the ATLAS trial looked at patients without pre-existing AFib. Enrollment is complete, follow-up is complete, and data analysis is underway. So my closing slide again, what's my take-home message? Surgical suture closure methods don't work. Excision works and exclusion of the appendage works. There is data to support left atrial appendage closure in the presence of pre-existing atrial fibrillation. There's no data to support prophylactic closure in the absence of pre-existing atrial fibrillation, and it may lead to higher rates of post-op AFib. And there's more data coming for patients at high risk. Last slide, I promise. So what would I do today? Not having facts doesn't always keep me from having an opinion. In patients with pre-existing AFib, eliminate the left atrial appendage. The data is clear. Patients without pre-existing atrial fib and at low risk for postoperative atrial fibrillation, it appears we should be leaving that left atrial appendage intact. What about patients at high risk for post-op AFib without pre-existing AFib? That's a judgment call. Personally, I would exclude that atrial appendage today. And I thank you for the privilege of the floor.